you want to talk a little bit about the role of chemotherapy in neuroendocrine neoplasm?
So traditionally, chemotherapy has been reserved for what we would now understand as a poorly differentiated neuroendocrine carcinomas. These are very aggressive cancers, much related to small cell lung cancer. And typically, platinum-based treatments have been what we have used, either carbo cisplatin, usually with etoposide, but some people have also used other agents. Recently, there's been more and more data about temozolomide. There was your retrospective series on temozolomide. And this year we had a really good study that was our first randomized controlled prospective trial of temozolomide in pancreatic neuroendocrine tumor patients, showing a benefit for the temozolomide and capecitabine combination over temozolomide alone. But I think the real key to that study was it really showed from a prospective fashion, that temozolomide was an effective agent. So I think temozolomide is becoming more and more frequent in its use among neuroendocrine patients. And as well, when we talk about the grade 3 neuroendocrine patients, both poorly and well differentiated, I think one of the most important trials we're going to have moving forward is this randomized trial that's being done to compare cisplatin and etoposide or platinum-based therapy of any sort as compared to temozolomide and capecitabine to try to understand that role. There has been historical studies with streptozocin and 5-FU in pancreatic neuroendocrine tumors. I think in North America, I think we very rarely use streptozocin now, and I think as we see the results of the temozolomide study increasingly disseminated, I anticipate streptozocin use will decrease more and more.
Yeah, and the study, of course, that you're referring to is the ECOG 2211 study, which was exclusively done in pancreatic nets. Patients with progressive pancreatic nets were randomized to receive temozolomide monotherapy versus capecitabine temozolomide. It was a randomized phase 2 study, so not phase 3, but I think the population was 145 patients, so relatively large by net standards. And the primary endpoint was PFS. It really actually showed a surprising improvement in PFS with cap-tem versus tem alone. I think with tem alone, the median PFS was 14 months. It was almost 23 months with cap-tem. And there was also an improvement in overall survival, which was quite encouraging. I think it's an important study validating cap-tem in pancreatic nets, and that really seems to be the population where it works best. We have a little bit more anecdotal information, I think, in lung nets. I personally have not found it to be that effective in midgut nets, at least as far as tumor shrinkage, although I sometimes use it for very aggressive midgut nets.
So I think outside of the pancreatic nets and perhaps even the high-grade nets, I think the jury is still out. I think we need to get more information, more data, and perhaps select the right patients, whether there's an understanding that potentially expression of MGMT methylation may help us understand who are those that respond and don't. So I think, and this goes for both chemotherapy, but for all the different treatments, I think we're doing a better job, and we need to continue studying to try to understand what treatments may be the right treatments for the right people. So there may very well be patients with either lung or small bowel nets who actually do quite well on cap-tem. I think we just need to identify them.
Yeah, and when it comes to prescribing chemotherapy, I find that often it's really important to do it right. So for temozolomide, you absolutely need to give the Zofran or other 5-HT3 blocker beforehand. Often that's not prescribed. And probably the main concern with chemotherapy, I would say, is thrombocytopenia. We see significant thrombocytopenia in probably about 15% of patients, although the rate that they saw in the ECOG trial was a little bit lower. So absolutely important to check a CBC just before each cycle, because the thrombocytopenia can be quite delayed. It starts on week 4, but then it can be maximized week 5 or 6. So if you see the platelet count dropping on week 4, you really want to monitor the patient closely.
So that brings up an important question. We do know that some of these, for example, can cause thrombocytopenia, and that may close the door to subsequent treatments.
Right.
So sequencing is always a challenge. Do you have a specific rationale for sequencing that you use? But I do think, when we are using treatments, we really want to be cautious of not shutting the door to other treatments down the road.
So, for patients with slow-growing somatostatin receptor positive metastatic nets, the first-line systemic therapy is easy. It's the somatostatin analog. But anything beyond that is complicated, particularly in pancreatic NETs. Right now, we have about 5 different options, right? We have everolimus, sunitinib, we have CAPTEM chemotherapy, we have PRRT, we have liver-directed therapy. And it's anyone's guess on how to best sequence them. And I think if you go to 5 different institutions, you'll probably get 5 different answers as to what the best sequence is. But you're right, you have to think about the long-term and potential interactions, for example, between chemotherapy and PRRT as far as bone marrow toxicity. So it's challenging. I don't know if I have a great answer to that. I think the only thing I would say with a relative level of confidence is that if you're dealing with a relatively aggressive high tumor burden, chemotherapy is probably a good option.
If it's an effective possibility.
For pancreatic NETs. For midgut NETs, I think it's a little bit easier. I'd say PRRT is probably the appropriate second-line systemic therapy for most patients, although for patients with liver-dominant disease, I still think liver embolization can be quite effective.
Yeah, I'm not sure we know the answers to any of these questions, but I think it's an important point to mention when we talk about sequencing is that we direct it on an individual patient level. We take the patient in the center of our care, and we're able to sort of understand that sequencing may be different for different patients. I don't think there's ever going to be one standard algorithm that we can follow. I think we really are going to individualize or taper our therapy for the patients, and one sequence might be right, as you mentioned, for one patient who has bulky disease may not be right for the patient who has low volume disseminated disease.